Hello everyone, welcome back again. Let's start with another topic, that is pelvic inflammatory disease. In the last lecture I've told you about the vaginal infections. So that was about the infection of the external genitalia or infection of the vagina, vulva and cervix. If the upper genital tract is involved, that is the upper part of the cervix as well as the uterus, the fallopian tubes and the ovaries are involved, or it is infected or inflamed, then that is called as pelvic inflammatory disease or PID. So let's start. What is PID? Coming to the definition, that is the infection or inflammation of the upper genital tract. Inflammation of upper genital tract, that is fallopian tube, ovaries and uterus. Cervix may be involved, but cervicitis and vaginitis, they are involved in the lower genital tract infection or infection of the external genitalia. So we can also write cervicitis and vaginitis are not involved in PID. This term is not PID. Okay, that is the infection of the external genitalia. Then most common route of spread is through ascending infections, that is via the sperms. That is the ascending infection. Okay, this is the most common route. And for genital tuberculosis, as TB is also a cause for PID, so for genital tuberculosis, the route of spread is hematogenous. The TB bacilli that travels through the blood or hematogenous route and it gets infection. What is the most common symptom? Most common symptom is dysmenorrhea. And what is the investigation of choice? Laparoscopy. This is the gold standard. Why laparoscopy is gold standard? I will tell you. What is laparoscopy? When we put the ports inside the abdomen and we visualize the uterus, fallopian tubes and ovaries by direct visualization we do. Okay, through laparoscope, that is the laparoscopy and that is the gold standard. And what is the surest sign for salpingitis? The surest sign of salpingitis is pus extruding from the fimbrial end. Fimbrial end of tubes. Okay, when we see directly, then that is the when the pus is extruding. See, if this is the fimbria, okay, this is the uterus, this is the vagina. So when we see the pus extruding from the fimbrial end by direct visualization from the port, okay, this is the surest sign. Okay, then coming to the organisms that are involved. What are the organisms? The most common organism is chlamydia. See, it can be PID can be primary and secondary. In the primary, the most common organism that is involved in is chlamydia. And in secondary, the most common cause is E. coli. What do we mean by secondary? That means if any other organs is affected, like if we are having any urinary or UTI, okay, urinary tract infection, and E. coli is present there, and E. coli causes urinary tract infection, UTI, and that E. coli, it traverses through the external genitalia and then it infects the upper genital tract through the ascending route, and then if it affects the upper genital tract, then that is called as secondary. Okay, understood? What do we mean by primary and secondary? Most common cause of primary PID is chlamydia, and most common cause of secondary PID is E. coli. Then what are the other causes? This gonorrhea, okay, mycoplasma, genitalium. And for secondary, group B streptococci, Klebsiella, and other anaerobes. Okay, then what is the most common? Let's write some one-liner. What is the most common cause of PID? That is chlamydia. Okay, then what is the most common route? That is ascending infection. Rice palms. Then what is the most common cause of acute PID? Or symptomatic PID, that is severe pain, abdomen or dysmenorrhea. Symptomatic PID, that is gonorrhea. It is very painful, or acute PID. Then most common cause of PID in virgin females is genital tuberculosis. And most common PID in postmenopausal is E. coli. Postmenopausal women is E. coli. So these are the MCQs, these are the questions. Okay, then what are the risk factors for PID? Multiple sex partners, low socioeconomic status, and also young age, any douching or history of instrumentation, or if partner is having infections, UTI or gonorrhea or urethritis, okay, that also causes PID. So what is the risk factor? Multiple sex partners, then history of instrumentation, douching, if partner having urethritis or gonorrhea infection, okay, then low socioeconomic status and young age. Young age PID is most common, that is from 10 to 19 years. Okay, then also if not using barrier contraceptive, chances of PID increases. Contraceptive the chances of PID increases. So, what are the protective factors? The protective factors are first, use of barrier contraceptive, use of pussy pills. Pussy pills also prevent PID, pregnancy and menopause. These all are the protective factors. And when what is violin string appearance? This is one of the symptoms that we find in the laparoscopy finding. Okay, we visualize some violin string adhesions. What happens when the fallopian tube is affected? When the fallopian tube is affected, the infection is spread from the fallopian tube to the peritoneum, and then to the peritoneum it spreads to the liver capsule, and then a string of adhesions is formed, and when it heals it forms string of adhesions from the liver capsule to the anterior abdominal wall, and that is called as violin string adhesions. So when the fallopian tube is affected, then it spreads to the peritoneum, causes abdominal tenderness, and when that heals, then there forms violin string adhesions, that is between liver capsule and parietal peritoneum. This is violin string adhesion. See, this is the liver, okay, and this is the anterior abdominal wall. So what happens? These are the adhesion, violin string like adhesions. When healed, it forms between the liver capsule and the anterior abdominal wall like a string. That is called as violin string adhesions. Then what is another sequelae is the Fitch-Hugh-Curtis syndrome. Fitch-Hugh-Curtis syndrome. What is that? That is another sequelae of PID. Okay, what happens here? Women with PID, when there is liver capsule inflammation due to active PID, then what happens? There is right upper abdominal tenderness, right upper quadrant abdominal pain. That is called as Fitch-Hugh-Curtis syndrome. Okay, that is another sequelae of PID. Then for diagnosis of PID, we use CDC criteria. Okay, use CDC 2006 criteria. What is that? What are the criteria? in this criteria, what happens? If one or more minimum criteria is present, then we say that the patient is having PID. One or more of the minimum criteria is present, and if any one definitive criteria. So what are the definitive criteria and what are the additional criteria and what are the minimum criteria? See, what are the definitive criteria? In definitive criteria, we directly see, that is laparoscopic visualization, which is the gold standard. Okay, which is here again the gold standard. So what we see? We see dilated hyperemic tubes, fallopian tubes due to inflammation, and if there is present of pus, that is pyosalpinx, and if there is tubo-ovarian abscess, tubo-ovarian mass or abscess, that is the definitive criteria. Okay, and then laparoscopy also, see, laparoscopy, once we do, it also offers the following advantage. What advantage? We can take directly, we can take the biopsy from the fallopian tube. Okay, so that we can send for the biopsy and then we can know the actual organism that cause the PID. So we can take the biopsy directly, we can take the biopsy from the fallopian tube. Directly take, and prognostic scoring for fertilization can be done. That is called as Boyer-Maser score. Okay, then what is the minimum criteria? Minimum criteria is lower abdomen pain, lower abdominal pain, okay, adnexal tenderness or cervical motion tenderness. See, this is the per abdomen finding. We see this one is the clinical criteria. We see clinically. Okay. So, this is the per abdomen finding. That is, on examination, on per abdomen examination, we palpate the abdomen and there is lower abdominal tenderness or pain. And there is also adnexal tenderness and cervical motion tenderness. How we see this one? We see by doing per speculum examination as well as the PV examination. In per vaginal examination, we introduce our two fingers inside the vagina and we see the cervical motion tenderness. Okay, when we move the cervix, there is cervical motion tenderness is present, and the adnexal tenderness. When we put the fingers inside the fornix, there is fornicial tenderness. Okay, so this is the PV finding and this one is the per abdomen finding. Okay, this is the per abdomen finding and these two are the PV finding or per vaginal finding. By introducing two fingers, we see the tenderness. And then what is the additional criteria? In additional criteria, if there is fever more than 38.3 degree centigrade or abnormal cervical discharge. Then increase in WBC, increase TLC, increase ESR more than 15 mm per hour, increase C-reactive protein, and lab documentation of either gonorrhea or chlamydia. Lab documentation of gonorrhea or chlamydia. Okay, so these are the additional criteria, that is fever, abdominal, cervical motion, or that is abnormal cervical or vaginal discharge, then increase in TLC, increase in ASR. These are all the inflammatory markers, increase in C-reactive proteins. Okay, and if there is lab documentation of the gonorrhea or chlamydia organism, then that is the additional criteria. And one disadvantage, see, this is the laparoscopy is the gold standard. So the problem is that when we do the laparoscopy, the endometritis cannot be ruled out. That is the inflammation of the uterus or the endometrium that we cannot rule out. So we do endometrial biopsy. So laparoscopy is gold standard if the superficial or the uterus, the peritoneum covering the uterus is involved, or the fallopian tube is involved, or the ovaries are involved. If the endometrium is involved, if we suspect that endometrium could be involved, then we do endometrial biopsy. That is for endometritis, as laparoscopy cannot determine endometritis, so we do what? We do endometrial biopsy. Endometritis cannot be diagnosed by laparoscopy. So endometrial biopsy is done. In case of acute endometritis, we see Witzel, and in chronic endometritis, in the endometrial sampling, we see which cells. See, here we see plasma cells, and here we see polymorphonuclear lymphocytes, polymorphonuclear leukocytes. Okay, polymorphonuclear leukocytes, not lymphocytes. Okay, so this one is on endometrial sampling. Okay, fine, understood. Then we can also use sonography for diagnosis. So what are the sonographical findings? Sonographical findings. See, normal fallopian tube, it is not visible in normal fallopian tube, it is not visible in ultrasound. Okay, not visible. If the fallopian tube is inflamed, or if there is infection, or if there is dilatation or distal blockage and increase pus or increased discharge within the or accumulation of the fluid inside the fallopian tube, then we can see the fallopian tube in the ultrasound. So fallopian tube, usually it is not visible in ultrasound, and when it will be visible in PID, it swells. Okay, the fallopian tube swells and lumen is occluded distally, and it is distended. Distance. And then what are the ultrasound findings? Distended tube, fallopian wall thickening, fallopian wall thickening. Okay, incomplete internal septas. These are the internal incomplete septa. So these are the ultrasound findings of the PID. So what are the signs on ultrasound? We see what? There is a distinct sign, that is the bead on string sign or the cogwheel appearance. That is beads on string. There will be, see, if there is, this one is the fallopian tube, what happens? There is repeated, due to repeated inflammation and resolution, what happens? There forms fibrosis in regular interval of the fallopian tube, blocking the lumen. So how it appears? It appears as beads on string. This is the cross-sectional view. In cross-sectional view, there is beads on string appearance. Also, cogwheel appearance. Okay, if this one is the cross-section, then due to repeated, there will be indentation. Due to repeated infection and healing, there will be fibrosis and indentation of the fibrosed bands into the cavity or into the lumen. That is the cogwheel appearance. Okay. Then second is the waist sign. In waist sign, we see this one is in the longitudinal section. See, I will show you the ultrasound picture. See, this is the tubes. When it is dilated, this one is the distal portion. Okay, so this is dilated, and this is also called as, this is the fluid filled lumen, distal lumen, and this is the dilated tube. This is the, what is this? This is the cogwheel appearance. Okay, this is the cogwheel appearance. And what is this? This is the longitudinal section, and there is an indentation here. Okay, this is the waist sign. Okay, this is the indentation. See, this one is the indentation, and this is like a waist. So this is the waist sign. Okay, then coming to the management, how to manage PID? First, we have to know the principles of management. What are the principles of management? Means how we should treat the PID. First, we should give the antibiotics that will cover both chlamydia as well as the gonococci or gonorrhea, and it will be started based on the symptoms. That is, we have to do the clinical diagnosis and we have to start the empirical antibiotics. And first we have to start the oral antibiotics, and later on, even after 72 hours, if there is no improvement, then we go to the injectable antibiotics. So these are the principles of management. So first we should give antibiotics that covers chlamydia and gonorrhea. Started based on symptoms. that is clinical diagnosis. And first we have to give oral, and then we have to wait 72 hours for resolution of the symptoms. That will pain will decrease, increase in frequency of urination, that will also decrease, and also the dysmenorrhea will decrease, and the painful intercourse, that will also decrease. Okay, so everything will decrease within 72 hours. If patient will be having fever, tachycardia, or increase in TLC count, that will subside. If it does not subside within 72 hours, then we give parenteral antibiotics. Okay, so this is uncomplicated PID. And if there is complicated PID, we have to do hospitalization. So, what is the indication for hospitalization? Hospitalization, we have to do the patients if PID with pregnancy, if there is presence of tubo-ovarian abscess, okay, and if continuous nausea and vomiting, so that patient cannot take the oral antibiotics, so we have to give the injectables as the patient is continuously vomiting or nauseating. So we have to admit and give the injectable. And in adolescent PID, adolescent, and also if TLC is more than 15,000, okay, and if failed medical oral treatment. If oral treatment is failed, or if there is PID with pregnancy, or if the TLC count is more than 15,000 and patient is nauseating or vomiting and cannot take oral antibiotics, then we have to admit the patients and give the what? We have to manage. Okay, we have to resuscitate the patient. Okay, we have to give adequate hydration, fluids, and injectable antibiotics, and then for the further symptomatic management for nausea, vomiting, all the antiepileptics will be given, and then we will wait for complete resolution. Okay. Now coming to the treatment, we can give in regimen A or according to regimen B. So first we give the oral antibiotics, as I've told you earlier, that oral antibiotics for 14 days. Okay. So first we will give in the regimen A, we can give ceftriaxone 250 milligram IM single dose, followed by doxycycline 100 milligram BD for 14 days. Okay, with or without metronidazole. And in regimen B, ceftriaxone is replaced by cefoxilar 2 gram IM with 1 gram probenecid. Okay, single dose. What are the indications for surgery if the tubo-ovarian abscess ruptures? Tubo-ovarian abscess ruptures, or if the size of abscess is more than 10 centimeter, and if abscess fails to respond within 72 hours. And also if patient is unstable hemodynamically, unstable Okay, so understood what the indications for surgery? Tube ovarian abscess if it ruptures or if the size is more than 10 centimeter, or if the oral treatment or even if the antibiotics or inpatient treatment it fails, then we have to do the surgery, and also if the patient is hemodynamically unstable. So keep learning. Thank you.